Welcome to PCOM Perspectives, where we discuss news, events, research, and other topics impacting our campuses and communities. Join us as we share our PCOM perspectives. Hello, and thank you for joining us. I'm your host, Dr. Jay Feldstein, and today we're talking with Jack Lynch, President and Chief Executive Officer of Mainline Health. Jack has served as President and CEO of Mainline Health since 2005, where he has overseen the management of four of the most respected acute care hospitals in the Philadelphia region: Lankenau Medical Center, Bryn Mawr Hospital, Paoli Hospital, and Riddle Hospital. Throughout his 20-year tenure, Jack's team has been credited with strengthening Mainline Health's commitment to safety, quality, and equity, and enhancing the technology necessary to support those key areas. He also created the system's annual Healthcare Disparities Colloquium, a staple conversation to address disparities in care and how to better serve patients and the community at large. Jack has also been dedicated to graduate medical education and undergraduate medical education during his tenure. Jack's strategic vision and dedication to enhancing patient care has been instrumental to Mainline Health's success, and we're pleased to announce him as our keynote speaker for PCOM's 2025 commencement ceremony in Philadelphia. Today, Jack and I will discuss his retirement from Mainline Health, the current workforce shortage, and addressing disparities in healthcare. Welcome, Jack.
Thanks, Jay. It's great to be here. I'm thrilled about the opportunity to address the student body and their loved ones and the faculty for commencement and really reinforce how important the relationship with Mainline Health and PCOM is. So we're proud to be a partner of yours, and I look forward to our discussion.
Me too, and I got a couple of questions for you.
Great.
The first one is reflecting on your 20 years as CEO of Mainline Health. What leadership principles have been most critical to your success?
You know, I've given this a lot of thought because they've changed over the years. I first wrote down listening, and many would say that, when did you develop that skill, Jack? I actually really think over time I began to understand the importance of listening. I think the work that we're doing together in Together for West Philadelphia is a great example where you and I maybe 10 years ago might have gone into that community and thought we had the answers. And I think at least you and now me have concluded that we need to go into those communities and listen first. So listening would be really an important leadership principle. Another one is to, act like I want others to act. I wrote down here that, everybody is every bit as important as I am, or as important as I think I am. I reflect back on a day when I was first here and I was walking down the hall and a security director said to me, Mr. Lynch, where's your name tag? I said, well, I don't need a name tag. I'm the president. And the poor guy looked at me like, oh, what do I say now? I said, Jeff, you will never catch me in the hall without my name tag on ever again. I'm just like everybody else in this organization. I need to be wearing my name tag. And I tell you that story because I think sometimes we get lost in our positions and we think that we're sort of above others in the organization. And the truth is, at this point in time, everybody on our team is very important. If they weren't important, they wouldn't be here. I think integrity. People have got to know that you're going to be transparent, you're going to be truthful, you're going to be honest. You're not going to omit the facts when the facts could change the outcome or the decision. You got to be willing to admit mistakes, particularly as we entered the space of talking about disparities of care and diversity and inclusion and belonging. As a white male, I have to understand there may be occasions where I say things that don't come across the way I would hope that they would have. And having an organization of team members that are willing to speak up when you do that is critical, but the only way they're going to do that is if you're willing to admit you made a mistake. And probably music to your ears is lifelong learning. You and I know that we were prepared, or maybe we weren't prepared for the jobs we got put into, but we know that every year that went on, we learned more, which made us better at the jobs we do. And I think as soon as leaders, or anybody, quite frankly, forgets that commitment to lifelong learning will make them and their organization stronger, it's a big mistake. Empowering others, and I'll end with that one. You and I as leaders can only do so much. I think one of the most powerful things we have is to empower other people to identify and solve problems and take action. And the farther up the organization those actions need to be taken to get approved, the longer it takes them to get done. And often they're not as good as they would be done if they were done closer to where the care or the education is occurring. So that's my list of first hits on principles of leadership.
I think they work for everybody in any industry. If you're a leader, and they're words of wisdom that come with 20 years of experience and success. So here's one I know is very near and dear to your heart. How has Mainline Health worked to level the playing field when it comes to addressing disparities in healthcare treatment and outcomes?
Again, Jay, just like you, we started asking tough questions. And quite frankly, you and I have colleagues around the country that aren't prepared to, or aren't willing to, or are very uncomfortable asking difficult questions. 14 years ago, we established the annual Disparities of Care Colloquium, where we literally challenged the organization and many of its clinical leaders, including students, to look at where there potentially could be disparities of care. Let's face it, 15 years ago, 14 years ago, to be asking that question was kind of bold. And we identified areas that were of concern. And over the last 14 years, we've developed a quality, safety, and equity dashboard that used to measure our 8 pages of safety and quality and equity measures by hospital. And it compared it to how the system was doing, red, yellow, green chart. And if you were green, you were doing well. And if you were red, you needed to improve. About 3 or 4 years ago, we moved away from just measuring the hospitals. And we now measure all of those metrics by aggregated groups: race, ethnicity, gender, age range, zip code, payer class. But once you start putting that data in front of people, particularly those responsible for delivering care and, quite frankly, allocating resources, it's a call to action. And so each of those gaps in care that are identified are then assigned to a clinical environment work group who has a multidisciplinary group that works on addressing, closing those gaps. And so those are the kinds of things that we have conversations about, we talk about. The other thing that I think that's been really critical for the last 10 years, embedded in our strategic plan, which the board approves, has been a commitment to identify and eliminate disparities in care. And that's a big step because, quite frankly, when you're willing to put that in your strategic plan, that states that you acknowledge that there are disparities of care. In the 2022 to 2026 strategic plan, we literally call it out this way: build trust, identify and eliminate disparities in care with the understanding that structural racism has affected confidence in the healthcare system. What we have found is that by saying that and using the word racism, it's not just about race, it's about all of the isms, but acknowledging that racism is a part of the challenge in getting at the bottom of disparities of care, the discussion and the work starts to move forward. So those are a couple examples of things that, I would say have really changed the landscape for us. We're very proud of the work that we do with you and many others, including faith-based organizations in the Together for West Philadelphia initiative, which is, really focused on improving the health of that community. We're very proud of the medical student advocate program that we've developed in partnership with PCOM, where your students get access to patients that are in our Lankenau Medical Associates practice, and they interact with patients that are having challenges, whether it's getting their meds, taking their meds, getting to their appointments, setting up new appointments, all things that I think give them more insight into the challenges that diverse members of the community face when seeking healthcare.
Great answer. Slightly easier question for my last one for you. How do you see medical education and graduate medical education changing in the next 5 years? And you can't ask me that question back.
I was getting ready to say, Jay, that's the question I have for you. I think that, and I think you'll agree, that medical education is critical to the future of healthcare in America. And with all that's going on, not the least of which is some of the safety and challenges in the healthcare environment, there are people questioning whether they want to enter the healthcare field. We're now talking to high school students about career opportunities in healthcare, not just for those that want to become a physician or a nurse, but every opportunity that exists in healthcare. But getting back to your question around GME, I think one of the biggest challenges we've got is nobody wants to pay for it. We all want it. We all want caregivers that are younger than we are. We want caregivers to be out there to care for our kids when they get to be our age, but nobody wants to pay for it. At Mainline Health, 65% of our patient admissions are government pay, either Medicare or Medicaid, and Medicare pays 75 cents on a dollar. Medicaid probably pays 60 cents on a dollar. And then there's additional funding for educational programs, but they continue to be cut back. The cost of training physicians, residents, medical students, nursing students, and other allied health professionals continues to rise. The other, quite frankly, really scary thing from my standpoint is the unionization of trainees. It creates, from what I'm told by people who have dedicated their careers to medical education, it creates a very difficult relationship with a learner and the faculty. Very different than the relationship that was in place for many, many decades. And I just don't think that that's going to add to the experience of a medical or surgical resident in their training program. And so I do worry about where all this is going. I suspect technology will help us in some ways with regard to teaching. I suspect AI and simulation will also continue to grow and be helpful. But let's face it, one of the most important pieces of medical education is how you interact with people. And while you've got to be an expert in the medical language and the medical knowledge, a lot of what the patient experiences, how that patient interfaces with that clinician. And all of that is so critical, and that can't be done on a computer or purely in a computer-aided simulation.
No, I agree. And like you, my biggest fear is with the unionization of residents, is the medical profession going to transition from a profession to a trade?
So when you think about it, I mean, there are lots of students that are being represented. We could talk about the student athletes. We could talk about resident assistants and graduate assistants. The training experience a resident experiences in a clinical environment is unique. And it's so critical to them becoming, an experienced physician. And it's not a pure employment relationship. It's one that requires respect from the faculty and an understanding that there's work requirement limitations, that we shouldn't be expecting residents maybe to do the kinds of training that they did 10 years ago or 20 years ago. But I think there's a balance. And I would like to believe that, strong clinical education leaders can do that very effectively without feeling the need or having the residents feel the need for representation from a union.
Well, now it's your turn. You get to ask me a couple of questions.
Well, I guess one of the ones that I wanted to ask you about is, with the healthcare industry continuing to face a massive workforce shortage, what is preventing academic institutions from producing enough qualified candidates to meet the challenge?
Yeah, I've given this one a lot of thought because it's multifactorial. Because what's happened because of all the increased hospital consolidation and just the change of medicine, and what you said, how no one wants to pay for graduate medical education and how expensive undergraduate medical education is getting, is that the lack of availability for good clinical experiential education is becoming rate limiting in our ability to increase the class size. The other factor that comes not only with the medical profession, whether it be allopathic MD schools or osteopathic schools, or the ancillary professions, physicians assistants, nurses, nurse practitioners, where accreditation by their own individual societies become the bottlenecks for expanding education. For example, only nurse PhDs can teach nursing students. A physician could teach, but it doesn't help them in their accreditation process. Same thing for physician's assistants. They need physician's assistants faculty to teach physician's assistant. They need physical therapy faculty. Whereas you could bring a physician in for a guest lecture, they don't count as faculty. So you've got rate limiting steps in the faculty process of education. So we've got these bottlenecks that are actually decreasing our ability to increase the output.
Yeah, the two I would add to that is the licensure process and the licensure requirements. We all want to move to people practicing at the top of their license. And then the other component is their professional associations. I'm not sure I understand why we've gone from having great physical therapists and occupational therapists with master's prepared education levels to, at least in the PT space, a doctoral requirement.
It's a doctoral program now, right?
Yeah. So what can a health system like Mainline Health do to help with this workforce shortage?
Well, I think just partnering with, with undergraduate medical institutions, schools that have these programs, potentially expanding the clinical experiential learning to be more outpatient focused. We tend to be so focused on inpatient care. The reality is, 20 years ago, 80% of the care was delivered in an inpatient setting. It's the exact opposite now. So,
Well, Jay, I've got good news for you. Mainline is absolutely focused on growing our ambulatory footprint. And I hope and look forward to the day that we expand the educational opportunities for students like yours and others into that ambulatory space for the reasons you've just stated.
we have to, because that's where the care is,
Yep.
and that's where the training needs to be. So I think that'll be an evolutionary process that obviously institutions like yours can help with. And also to partner, like if you decide, hey, we've got a shortage in this area, what programs could we develop together? One of the interesting areas that we're seeing in other parts of the country are anesthesia assistants. There's a shortage of nurse anesthetists and anesthesiologists. And for hospital systems to staff their outpatient surgery centers, there's a workforce shortage there. Well, anesthesia assistant programs are 26-month programs. They're basically physician's assistants just targeted for the OR and anesthesia. And some states are licensed to be able to do that. Georgia, Texas, Pennsylvania can't get a license.
Yeah, what we're going to see there is exactly what we see with the turf over
It's a turf
the
battle.
CRNAs and the MDs and DOs.
And they don't want anybody else in.
No.
So, but those are areas, and whether if you need, this gets back to, what can be a technician as opposed to what needs to be a master's level or doctoral level, and what programs could we develop together, not only with the local undergraduate schools, Community College of Philadelphia for technicians, whatever it is that we can all do together to create the programs we need to meet the workforce solution. And it needs to be state and city partnerships as well for funding.
The other thing I think that you and I would both sort of be adamant about is what you're talking about is not a willingness to cut back on our commitment to quality and safety. There are top of license items that physicians should be doing. There are top of license items that CRNAs could be doing and should be doing. And to your point, there are other things that take place in the anesthesia space, and there are other examples where an assistant could be very, very helpful, and it's worked in other areas in healthcare without diminishing quality or safety.
Right.
I've got the toughest question for you that we could spend 20 minutes talking about just between the two of us. But what is your approach to navigating governmental actions and uncertainties that can surround them, that could impact the future of higher education and healthcare?
Retirement.
Come join me.
I'm kidding, Jack. No, I can't think of a more appropriate question in the time we're living in right now. I mean, in my 10 years here, it's just been the most uncertain environment from a governmental standpoint I've ever experienced. Besides the traditional approaches, which is, getting people, motivated to understand the impact of elections and policies, how to reach out to their congressmen and senators for things that adversely affect healthcare education. The most important thing that we're trying to do and I'm trying to do is just to stay focused on our mission. What are we here for? What can we control and what we can't control? We can control how we vote every 2 to 4 years in elections, but in the meantime, how do we make sure that we're turning out a highly educated, compassionate, well-rounded healthcare provider, whether it's an osteopathic physician, a physician's assistant, a mental health counselor, a physical therapist, a pharmacist, to be focused on, taking care of patients from all walks of lives, to being educated in a safe, inclusive environment, regardless of gender, ethnicity, sex, religion, whatever it is, respect amongst faculty, staff, and student, and to take that respect going forward when they're out to build a healthy community and take care of patients. That's the best we can do. And that's what we stay focused on.
That's why your work is so important. It really is the beginning of that health professional's career in understanding the importance of what you just described. One of the areas that we're both being challenged right now is the whole DEI space. And one of my concerns is if we move away from DEI and what that defines, we move away from the word DEI and really think about our commitment to eliminating disparities of care. I think evidence would show that when you have a diverse group of people around the table making decisions about care that's being provided or systems that are being put in place for care, the more diverse that table looks, the more likely you're going to meet the diverse needs of your community. We're very focused on having a board, a leadership team, a medical staff that looks like the community we serve. And if we want to do that, and I think most would agree that you don't have to have anybody being compromised in order to have your organization be made up with people that look like the community you're serving, you've got to develop programs around the promotion of, the development of, the training of, the education of a diverse workforce. And those things are being called into question right now. And I worry a lot about what is that going to do to our ability to, quite frankly, eliminate disparities in care. You know, I heard a great quote the other day that I wish I could take credit for, but somebody else said it. It can't be wrong if you do the right thing.
Right. And that's, exactly what we're just going to continue to focus on, the right thing, and we won't be wrong. And I can't think of a better way to end our podcast for today. Jack, thank you for joining us today, and thank you for your 20 years of service promoting safety, quality, and equity in healthcare. We're honored to have you join us at this year's commencement ceremony, and we wish you the best of luck in your retirement. I'm Dr. Jay Feldstein, and this has been PCOM Perspectives.